building towers that are high and you can see the clouds when you come by.
Good morning. Welcome to the 2015 UIC Urban Forum. Are we on?
There's only something more than what you think. A higher self deep within. There's only
I can lip sync. Oh, there it comes. Good morning. Welcome to the 2015 UIC Urban Forum. Thank you for being here with us. I understand we have some traffic issues, which are probably delaying a lot of people. We'll be coming in, but I think we need to start the program. So welcome. My name is Michael Pagano. I'm the director of the UIC Urban Forum, and on behalf of UIC, the Board of Trustees, co-chairs Tony Preckwinkle, Chancellor Michael Amaritas, and Chicago Community Trust President Terry Mazzani, I welcome you to the 4th Annual UIC Urban Forum and the 21st Annual UIC Hosted Conference on the Urban Challenges of Contemporary Society. The theme of this year's Urban Conference is Remaking the Urban Social Contract, Health, Energy, and the Environment. It's designed to engage all people in a broad discussion of what constitutes a social contract and examine those ideals that are part of our society and those that belong to the individual. The conversation today brings together people from various places, organizations, and institutions with a variety of ideas, activities, and programs. The order of the day is outlined in your program. After the 2 morning panels, at which an audience Q&A is scheduled, a box lunch will be available in the room next door. It's called Room A. It's on the other side of those curtains. The afternoon sessions take place behind this large room on the 2 floors. The panels begin at 1 p.m. and 2 other panel sessions will begin at 2:30 p.m. After the last panel ends at 3:45, we will return to this space and a keynote conversation on one of the great experiments in creating a social contract or compact is the Chicago Community Trust's On the Table program, and that will take place at 4 o'clock. Terry Mazzani, CCT President, and Dr. Joseph Horath, the Director of the Institute for Policy and Civic Engagement, will release some of the findings of the OTT program and outline an exciting follow-up project that's designed to build on the work of the UIC Urban Forum. So please join us at that time and come prepared to ask questions. So that we can continue to offer a high level of conference next year at the same time, I think there's an evaluation form, and if not, just send me your comments and we will take care of those for next year. The UIC Urban Forum recognizes our partners in this undertaking, including the MacArthur Foundation, Public Media WBEZ, the Chicago Community Trust, the College of Urban Planning and Public Affairs, and the Institute for Policy and Civic Engagement. Thank you for your support and collaboration. It's now my privilege to introduce the official welcoming team to the UIC Urban Forum, President Timothy Killeen of the University of Illinois and Chancellor Michael Amaritas of the University of Illinois at Chicago. Chancellor Amaritas is a chemical engineer who, before coming to UIC just last March, served as provost at the University of South Carolina. He's also taken on the mantle of chief advocate for UIC in the city of Chicago and nationally, having just returned from the White House last week where he met with the president. He's jumped right into Chicago's vibrant business community and neighborhoods to showcase the wealth of knowledge and expertise available at UIC. It is his stated goal that when Chicago needs solutions, UIC is the first place they turn. President Killeen, who began as the U of I's 20th president just last May, is committed to continuing the University of Illinois' rise among the world's elite. In his words, quote, firing on all cylinders, to educate and empower students, and to foster the pioneering innovation that drives progress and economic growth. I'm honored to turn over the microphone to President Killeen to kick off this year's UIC Urban Forum, Remaking the Urban Social Contract, Health, Energy, and the Environment.
Thank you, Mike, and good morning, everybody. This is a really important thematic set of topics that you're going to be dealing with. It's my honor to welcome you to UIC, Chicago's largest university, Chicago's best university, Chicago's most important university, and the university where I'm honored to be a faculty member. It's one of the 3 great campuses in the University of Illinois system, and we're using the word system more frequently now because we're looking at synergy and connections and collaborations to influence the prospects of the state of Illinois, which I think is in need of some assistance. For more than 30 years, UIC has been fulfilling late Mayor Richard J. Daley's vision for a premier public university in the heart of the great city of Chicago. It has done this through a set of world-class academic programs that attracted a record 29,000 plus students this fall and led UIC's 20-spot jump in this year's U.S. News rankings of the nation's best colleges. Not that we pay any attention to rankings. And it's done it by leading-edge research and a legacy of innovation that has moved UIC up to 62nd among U.S. universities in total research funding. Those are important steps, but you ain't seen nothing yet, is my phrase about UIC. And all this has happened in a time frame mostly within human memory, or of course the medical school goes way back. But most importantly, and something to take great pride in, I believe, is the unwavering commitment to public good that's truly reflected in this forum and is in the marrow and genome of UIC, and it's something to be extraordinarily proud of. It's been UIC's purpose from the very beginning, a core mission rooted in the U of I's founding nearly 150 years ago as one of the nation's original land-grant universities. So we're taking the land-grant mission of academia serving public good into the world city of Chicago, and what an opportunity that brings. But we exist to serve not just students, although the transformation in first-generation students is palpable and obvious, but we exist also to really lift society, producing a highly skilled workforce, pioneering discovery, and social good and equity that leads the way and is needed for progress and prosperity. It's not a goal we chase alone, it's a collaboration, a partnership with our colleagues in the academy, with government, with business, and in industry. In the words of Henry Ford, if everybody's moving forward together, then success takes care of itself. And I think moving forward together is what we're called to do collectively right now. And that, of course, is the foundation for this annual forum. And I'm deeply grateful to all of you for sharing your time, your talents, and your visions. And those of us in higher education know a little about the underlying theme of this year's conference, about social compacts. For more than 3 decades, we've seen a steady fraying of the social contract that's long been the backbone for public higher education in the United States. And I want to talk just briefly about that with you this morning. In 1980, state government covered more than half the costs for the academic enterprise at the University of Illinois. It signaled a recognition that higher education is central to the common good, that society in general benefits when government invests to help unlock the potential of every deserving student. But that long-held social contract has been eroding. Today, state funding covers less than 15% of our operational costs, and deeper cuts loom as the legislature and the administration work together to resolve an ongoing impasse over the fiscal 2016 budget. It reflects a shift in thinking, in my mind, that higher education most benefits the individual as a private good rather than the whole as a public good. That, in turn, erosion has led to tuition increases that are putting college out of reach for some students and families. We can't go down that path anymore, and that's why we are holding the line at the University of Illinois, and we cannot siphon away dollars that support academic excellence. The dwindling investment has serious consequences, and I hope you will all join me and others in declaring the importance of the value proposition of public higher education in the state of Illinois. Because erosion there threatens to constrict the pipeline of talent and innovation that is crucial to the future of our state and our nation. But like all of you here today, we're not giving up and throwing in the towel. The stakes are too high. So we're going to continue to make our case and imagine new solutions that will forge a new social contract for public higher education in the state of Illinois for a new era, one that will ensure that we continue to transform the lives of students and their families and lead the way, really lead the way to economic revitalization of this state. This perspective mirrors all the work you undertake today as you examine the role of government in stewarding healthcare, energy, and the environment, all areas that are equally critical to the public good, and all areas for which you need the comprehensive intellectual powerhouse of a full research university like this. So our goal is the same as yours, a better tomorrow for the people of this great city and beyond. Thank you again for your commitment, and I look forward to working with you. And I apologize for the bully pulpit moment, but I can't resist. Now it's my pleasure to introduce Michael Amaridis, who assumed the role as 9th Chancellor of UIC on March the 16th. He's my good buddy, and in the last 6 months, he has met exhaustively in small groups with more than 2,200 students, faculty, staff at every college across the campus, with his message of dynamic efficiency and a culture of innovation in action. That is truly what we need. He's also taken on the mantle of Chief Advocate for UIC in the city of Chicago and nationally, jumped right into Chicago's vibrant business community and neighborhoods to showcase the wealth and knowledge and expertise available at UIC. And it's his stated goal that when Chicago needs solutions, and because of Chicago's role as a world city, when the world needs solutions, UIC should be and is the first place they turn. So please join me in welcoming Dr. Michael Amaridis.
Good morning. It's always great to hear your boss say such great things for you. It's my pleasure to add my voice and welcome all of you to our campus and to the 2015 UIC Urban Forum. And I want to thank especially our co-chairs for this year's forum, Cook County Board President Tony Preckwinkle and my good friend, Chicago Community Trust President and CEO Terry Mazzani, for their support and their presence. We're proud to continue our long-time commitment to a national discussion of the vital issues facing our cities and our urban areas, and to host today this impressive group of speakers and participants that has been assembled and is ready to offer their insights and unique perspectives on the issues that we are facing. USC has in fact been hosting an annual conference devoted to urban issues for 21 years now, and this should not be a surprise to anyone. Because we are located in the center of one of the world's greatest cities, we are located where the people are, where the problems are, and where the opportunities are. And whether it's the infrastructure issues, whether it's the healthcare and education issues, whether it's the ethnic, cultural, and religious diversity issues, or whether it's the issues related to energy and the environment, they're all right here in our front door, and we feel the need to address them. Since 2008, for the first time in human history, more than half of the world's population lives in cities. And cities like Chicago are the early sensors, in my opinion. They're the places which all the issues affecting the population of the planet are felt first, and they're felt in an acute way. Given the fact that the global population has by now become interconnected in ways that didn't exist a century ago, when a problem hits one pocket like Chicago, the ripples are likely to be felt around the world and to be felt very quickly. And to be sure, health, energy, and the environment, which are the issues today, are also more interconnected and more interdependent today than ever before. And that's where the role of an urban serving university like UIC comes into play. The University of Illinois at Chicago was created by and for the people of Chicago and the people of Illinois. As the President pointed out, we are Chicago's largest university. We are Chicago's only public research university, and our trajectory and success are also interconnected and mirror that of our host city. Mayor Daley said that great cities make great universities, and great universities make great cities. And we are focused, and we will continue to be focused on Chicago, making it our priority, not only to educate our young people here, but also to address, through our research, the key problems facing this city, and to work with our surrounding communities to improve the lives of its citizens. After all, we take very seriously our role as the university for Chicago. Today's discussion and today's focus on remaking the social contract is particularly important and timely, as the President pointed out. The quality of urban life depends upon the capacity of large metropolitan areas to respond to the challenges of the global era, with challenges in the health, environmental, and energy arenas being front and central. And what we have sometimes seen over the last 3 to 4 decades has been what you would consider a breakdown in the relationship between what society needs and what our government provides. Defining the needs will inevitably invite a political discussion, and that's not the point here today. The facts remain that the public has a right to demand and to expect a return on our investments, and I view my taxes, I don't know about you, but I view my taxes as an investment in the form of affordable quality health care, a clean environment, and safe energy. These should be a critical part of a new social contract. And of course, an essential part of a new social contract should be support for higher education. Because it is at the university level that many of the urban issues we discuss today can be analyzed and that's important, and can be solved. As the forces of urbanization and globalization reshape our world, it's critically important that all people have access to higher education. I'm worried about a new segregation in higher education. I'm worried about a segregation along financial lines between those who can and those who cannot afford higher education. And I'm worried because financial lines in this country also coincide with racial lines. And we know the negative effect that this will have in the fabric of our society. So as President Kalin noted just a few minutes ago, and as we have seen our support for public higher education eroding and dwindle by now to less than 15%, actually it must be closer to 12% by now, and of that 15%, this year we've been asked to prepare for a 30% reduction. It's important to remember that for cities to ensure the health, safety, and well-being of their citizens, it is vital that we put public higher education at the forefront as we rebuild a social contract. The intellectual infrastructure needed to deal with all of the issues that will be discussed here today, health, energy, and the environment, is built within the walls of higher education. And it's important to preserve high-quality, urban-serving public universities, among which UIC is the gold standard nationally and internationally. And as part of our contract, we can reassure you that it is our role to play in securing these issues as human rights, and we will always continue to do so at this university. It is forums such as this one today which provide an opportunity to share experiences and to hear from those on the front lines about the best paths forward. And our hope is that we will define some of these paths just here and today in your meeting. So thank you again for everyone for your participation, and I hope that at the end of the day you will have the beginning of some new solutions in the areas that we are addressing. Thank you.
And now welcome to the beginning. Thank you, Chancellor Emeritus and President Kalin. The first morning panel on rebalancing the scales, the new social contract for health, energy, and the environment will be moderated by Natalie Moore of WBEZ. The other panelists are Dr. John Lumpkin, Senior Vice President of the Robert Wood Johnson Foundation, Dr. Lamar Hasbrook, Executive Director of the National Association of County and City Health Officials, and Dr. Jay Shannon, CEO of the Cook County Health System. Welcome.
Good morning, everyone. I'm glad to be back here again at the UIC Urban Forum. Thanks for being here, and thanks for braving the traffic. I know that I got stuck in it too this morning. So what I would first like to do is just have our panelists give some opening statements, and then we'll have a discussion, and then we'll have some time for questions at the end. John, I'll start with you.
Great. Well, good morning. And it's a pleasure to be back here at UIC. I'm honored to have studied here and received my master's in public health. You know, some of the online materials for this meeting, there was a paper by Bill Kling and Emily Steele that wrote in a very fine paper, and I encourage all of you to take a look at those that are online. The following question was posed. If social contract is designed to promise the greater good, why are our infant mortality rates, teen pregnancy rates, tobacco usage, accident rates so high, particularly as compared to other westernized countries? You know, reading this brought me back to an inflection point during my residency when I was studying emergency medicine at the University of Chicago. It was a pivotal point that ultimately led me here to the University of Illinois in the School of Public Health. It was late one night when a 16-year-old young man came in with a single gunshot wound right here in his chest. The crew that had been on, the residents who were on, were well trained because this was a time where there was a lot of trauma that we were seeing in our emergency department. One of the residents put a tube in his throat to help him breathe. Another resident put in a line, and as he got on the table, this young man took his last breath. It was one of those pivotal moments in a medical career. It was my job to take the scalpel, to open up his chest, to reach inside, and to remove a clot from around his heart. And in my hands, I could feel his heart starting to beat, and he started to wake up. He was taken upstairs, and a small cut about an inch in his heart was repaired, and he walked out of that hospital. What happened was that a couple of days after this injury, I went up to visit him in his room, and he looked at me and he said, "Doc, you know, I'm really glad that you're so good, because when I get out of here, the guy who shot me is going to be right back here in your ER." So here was a moment of medical triumph, yet human tragedy. And human tragedy that wasn't just this one individual. So at that point in my career, I began to say, you know, I really feel that it's important for me to do something more. And that's why I came here at the University of Illinois, Chicago, to get the tools to begin to look at a broader context of health. One that not only developed expertise in treating injuries, but even more importantly, in preventing illness and injury. And that is the essence of the challenge that we face as we talk about the health of our nation. If the social contract is designed to promote the greater good, why are our infant mortality rates still so high? Well, the data is clear about our health in this country. We spend more per capita on health care than any other nation in this country. Yet our people die younger, they're more likely to be obese or overweight, and we lose more people to violence and drug-related deaths. Yet there are those who argue that the differences are not the province of health care. Rather, they're the results of the characteristics of our society, our culture. Don Berwick, former director of the Centers for Medicare and Medicaid Services, said that every system is perfectly designed to get the results that it gets. It is our customary beliefs, our social forms and material traits as a group that impact our health. In other words, our culture as a nation. And we have a culture in this nation that promotes unhealthiness. Just yesterday, the Centers for Disease Control reported that every day, 1 out of 3 children in this nation is eating fast foods. That our communities are no longer walkable because of the design of the community, or people are afraid to walk on the streets, or both. That is why the Robert Wood Johnson Foundation has committed to help our nation change from a culture of illness and unhealthiness to a culture of health. A culture of health, and how does that fit within the context of a social contract? The social contract is that government has the duty and promise to protect, that individuals have the duty and promise to make good choices. Yet I would argue that there are others who are involved, that business and nonprofits and other sectors in our society and throughout our communities have to be engaged if we are in fact to make progress on improving health. You know, humans tend to make easy choices rather than hard choices. Just think about the last time you were at O'Hare Airport and you wanted to eat something healthy. That was always a challenge, and it remains to be a challenge. And so you make the easy choice and you go eat something that's unhealthy. Well, how easy is it to find healthy food in some of the communities that are just a stone's throw from where we are today, or other inner city communities across the country? We have to realize that if we're going to do better and be healthier as a nation, that we need to change our society where we live, learn, work, and play. To make healthy eating the available and the preferred choice. To make activity and exercise a part of everyday life. So we will know as a nation that we have achieved a culture of health when being healthy and staying healthy is an esteemed social value that guides public and private decision-making. That health becomes a part of every policy that we make as a nation. And when more communities begin to follow the example of Brownsville, Texas, right on the border with Mexico, where there are high rates of poverty and people are living cheek to jowl, struggling to make the ends meet. But they also have high rates of heart disease, diabetes, and obesity. There, they developed a community advisory board of 200 businesses and organizations and individuals. And they did things in the community to try and improve the health, like building the Brownsville Bike Barn, a converted garage where someone, by donating 25 hours of community service, would be able to own their own bike. And by converting some of the streets downtown and closing them off on the weekends so people could come in and walk and stroll and push their baby buggies. And businesses would come in and make available water and fresh fruits. And not only did it help improve the health of the community, but the businesses on that strip actually did better in revenues on the days when they had these streets where they were closed to traffic. Or individuals such as David Stagner, who's a cardiologist in Columbus, Ohio. And he was working day after day seeing people come in with heart disease, and would come out and he would say, you know, you really need to eat better and you need to exercise. And one winter day, he was so frustrated because a guy had come in and just promised him 2 months earlier that he would begin to exercise. And he said to him, you know what? What are you doing on Saturday? Meet me at the park. And that weekend, it was one person. By spring, it was 100 people. And now these Walk with a Doc programs are available in 150 communities across the country. Changing culture is hard work, and it takes time. Government, business, nonprofits, and individuals must come to accept that health is a shared value and that all policies have some health impact. And that if we aren't intentional, that impact can be bad. But we are intentional and pay attention, we can implement policies that will improve health. That it requires cross-sector collaboration to improve well-being. Improving education is an example. We talked about earlier, you heard the President and the Chancellor talk about this great institution. Well, here's a health fact for you. When compared to people who have not completed the 12th grade, individuals who graduated from college live 9 years longer. Education is important to health, and educators have to be involved in the conversations we have in our community about the health of our community. We need to recognize that we are all in this together, and we have to work together across all sectors to create healthier communities. And we cannot make progress in our communities without everyone in our communities making progress. And all too often, it is the poor, it is the minorities who suffer many of the health effects, and we can't be healthier as a nation without addressing those. And we must work together to strengthen the integration of health services. The vast majority of money that we spend, over 17 to 18% of our gross domestic product, goes into healthcare. We can no longer continue to afford that without better returns on our investment and leveraging those funds to be able to do prevention and public health interventions. And if we do this, government, individuals, businesses, all sectors of society working together, we can build a culture of health where the healthy choice becomes the easy choice, enabling all in our diverse society to be healthy now and for generations to come. So that 20 years from now, at this same forum, the question will not be if the social contract is designed to promote greater good, why are our infant mortality rates, teen pregnancy rates, tobacco usage and accident rates so high? There, the question will be posed is how can the social contract keep this nation and help it remain as the healthiest nation in the world? Thank you.
Lamar?
Thank you, and good morning. Thank you to the Urban Forum for having me. I'm also delighted to be back here. I had the pleasure of giving the commencement speech on the stage just last June for the School of Public Health. So I'm Lamar Hasbrook. I'm a medical internist by training. I've practiced public health and medicine for the last 25 plus years. And I've had the experience and the privilege of leading population health improvement efforts at the local level, at the state level, at the federal level with CDC, and at the global level with the World Health Organization. I currently am the executive director for NACCHO, not NACCHO, NACCHO, the National Association of County and City Health Officials, and we are a membership association that represents the nearly 3,000 local health departments across the entire country responsible for the health and wellness and protecting the health of nearly 220 million Americans across the country. So everything I tell you and the perspective I share is going to be informed by that lifetime professional experiences working at the different levels in terms of population health improvement and public health. So when I look at the issue of the social contract, I really feel like local health departments really epitomize what a social contract should be. In fact, the entire governmental public health enterprise, which includes local health departments, state health departments, and federal agencies such as the Centers for Disease Control and Prevention. And I say that because these three kind of work together, these three sectors of governmental public health enterprise work together in a way that, number one, assumes that there is inherent value in health and wellness for populations. Number two, they're all funded by taxes, so the American people actually fund, or society funds this social contract. And three, they all have the business of really trying to promote health, prevent disease, protect the community from threats, and ultimately, they're ultimately trying to reduce premature death and improve the quality of life of our citizens. So public health covers the whole waterfront, from protecting the water, protecting the air, everything from infectious disease outbreaks, which we learned very astutely during the Ebola outbreak, from chronic disease management to newborn screening, vaccinations, vaccine-preventable diseases, making sure the food's fine, and making sure that environmental threats are kept at bay, be it asbestos or lead or whatever have you. And that's really the role of public health in addressing the context. But there has been an erosion of the social contract with regards to health and population health in my mind. Number one, I say that because even in looking at the local health departments, there's been an erosion in the workforce. We've documented that over the last 6 years, the workforce has declined by more than 50,000 individuals working in public health. Number two, we know the budgets have been basically decimated in terms of society and local communities and even the federal government putting the dollar, the prevention dollar, in public health and in population health concerns and population health activities and approaches. And then number three, I would argue that there's been kind of a drift in the philosophy in terms of us inheriting this mistaken belief, in my opinion, that health is equivalent to health care. That if we can address health care, make sure everybody has health care, then somehow they're going to be healthy. And communities and families are going to be healthy because they have an insurance card that they may or may not be using, or because there's a clinic in their neighborhood. And so what we need to understand is that really that health care happens way down the line in terms of the continuum of health. It's what happens in your context every day that determines if you're going to be healthy or not. So in fact, there are real determinants or drivers of health, but also of wellness and disease and premature death that are beyond the walls of the clinic and that are beyond the reach of the healthcare delivery system. In fact, it is the context, it's the everyday context that we live in that really drives health. It's the things that Dr. Lumpkin mentioned in terms of education and looking at the education gradient of health, income and the income gradient of health, employment, and those things that conspire together to result in where a person lives, their place in terms of where they live, where they work, where they play, where they're educated, that really conspire to either enforce, reinforce, or enable behaviors that ultimately help people to be healthy. It's the environmental context, those environmental threats, those environmental toxins, but it's also the enablers that make the healthy choice, the easy choice for individuals who go about their daily business of trying to live their whole lives. So I'll put it this way. One cannot expect to be healthy simply because they have access to a clinic or to a doctor or to an insurance card. We know that it's important to see a doctor, healthcare provider, to get your preventive health done, your screenings, your vaccinations. It's important to address acute or emergent care. We talked about the trauma centers here in the Chicago area. Maybe we'll talk about that a little bit later, in terms of helping you to manage your chronic diseases. But at the end of the day, the average person may have 2, maybe 4 touch points with a healthcare provider per year. So that's 4 days a year. What happens in the other 361 days a year really determines if you're going to be healthy or if you're not going to be healthy. But if we can reside in a place where there's a context and there's a culture and there's values of health, shared values of health and wellness, where the healthy choice is the easy choice, and where there's institutions in that place that we reside that stands ready and prepared to protect one from emerging health threats, be it the environmental toxins or infectious disease outbreaks like Ebola or the measles, natural disasters, obesity, inactivity, poor housing, violence, vaccine-preventable diseases. If we live in that kind of place and we have access to healthcare delivery systems, then one can reasonably expect to be healthy. One can reasonably have an expectation of health. So in regards to the social contract, I would say, and specifically with the role of governmental public health, it's important for us to use the data and the information to prioritize, to develop joint policies, and to support practices that really have the aim of addressing these factors rather than spending $9 every $10 for healthcare delivery, thinking somehow if we have access to health providers, we're going to be healthy. So I look forward to having that dialogue as we go forward. Thank you.
Good morning, and I'm also grateful to be asked to join the forum this morning. I think I may have been set up because I run a healthcare system. So my name is Jay Shannon. I'm an internist as well. I'm a pulmonary and critical care physician, and I'm the Chief Executive Officer for Cook County Health and Hospital System. I would agree with all the comments that have been made by Dr. Hasbrook and Dr. Lumpkin, but want to tell a little bit of a different aspect, if you will, of the social contract and the way that it's evolved literally in the last couple of years locally here in Chicago and Cook County because of the Affordable Care Act. Because I think that the Affordable Care Act has been transformative for our society from the standpoint of access to health care. And I want to tell you a little bit of that evolution here, give a little bit of context to that, and tell you why I think it has been a meaningful change. But first, let me take a step back and I'll tell you a little bit about the Cook County Health and Hospital System, because as I tell people when I'm out with them, it's not your father's Cook County Hospital, which is the organization that I first joined in 1990. Today, the Cook County Health and Hospital System really consists of 4 major parts. Those parts include our clinical care delivery system, which is Stroger Hospital on the west side here, Provident Hospital on the south side, and then 16 community-based clinics, 3 regional ambulatory centers for specialty services and diagnostic services, and the Core Center, which is the largest provider of HIV services in the Midwest. In addition to that, we operate and provide healthcare services for detainees at the Cook County Jail and the Juvenile Temporary Detention Center. Those 2 places on any given day house anywhere from 8,500 to 10,000 individuals who are awaiting trial. The overwhelming majority of those folks haven't been convicted of anything, but they're too poor to post bond. They've got a federal right to care, and we provide that care. I'd point out we provide that care to the tune of about $80 million of unreimbursed costs per year. It's a critically important place that we think offers our system an opportunity to address some of the public health inequities that Dr. Hasbrouck alluded to. The third part of our health system is the Cook County Department of Public Health. And just at a high level, again, Dr. Lumpkin and Dr. Hasbrouck both ran the Illinois Department of Public Health in the past. When you get down to the local level, if Illinois has 12 million people, about 5.7 million of them live in Cook County. About half of them are in the city. Later today, Dr. Julie Morita, who runs the city's Department of Public Health, will be speaking with you all. And about half of those people in Cook County live in suburban Cook County, and we run the public health function for suburban Cook County. It's vitally important. It's a little bit more complicated because whereas in Chicago there's one mayor, one fire marshal, and one police chief, in suburban Cook County there are about 128 of those across many municipalities. The last and the newest kid on the block in the health system is County Care, which is the Medicaid health plan that was born out of an opportunity that our health system seized back in 2012 when we saw the Affordable Care Act coming into a reality, slowly over time, but with really a start date for expanded access to care in 2014. Today, County Care is the largest single provider of Medicaid health insurance to residents of Cook County. We have approximately 170,000 members in that plan. And I do want to just speak to one of the issues that Dr. Hasbrouck raised, which is the issue of access to care, and I'll talk about that a little bit. But let me talk first of all about where things were and where we were starting from in 2012. So you'll be aware that, as Dr. Lumpkin pointed out, we're the wealthiest country on the planet. But in 2012, we had approximately 47 million people living in the country who did not have insurance. Now, with the Affordable Care Act, one of the key features of the Affordable Care Act was the expansion of the availability to insurance, and that was going to happen through two major mechanisms. One was through expansion of Medicaid eligibility. Historically, Medicaid was tied to welfare benefits like housing and food stamps. And so the people who got Medicaid prior to the Affordable Care Act expansion in 2014 were children and parents of poor children, and then disabled people. With the Affordable Care Act, a big part of that was expansion of that to poor individuals. So what's a poor individual? Well, under the Affordable Care Act, if you're in one of the half of the states in the country that accepted the expansion of Medicaid, a poor individual was defined as somebody who's making less than 138% of the federal poverty level. What that means is an income annually of $16,000 or less. Now, if you think about that, what it takes to live on $16,000, you can understand the difference between having insurance and what that can mean. So in 2012, it was estimated that something like 330 to 350,000 adults in Cook County would be eligible for Medicaid under the expansion in 2014. We talked with the Centers for Medicare and Medicare Services, and they granted us a waiver that gave us a head start to take care of and enroll those people into Medicaid. I shouldn't say a head start to take care of them because historically, my health system has been the provider of care for those individuals. The problem was the way that we were providing that care. So I first started at Cook County in 1990 as a primary care physician and an emergency room physician, and subsequently morphed through a couple of different roles there. But I can tell you that in 1990, what we did was we waited for people to come to the hospital sick, we resuscitated them, and we discharged them, typically with a good luck and a God bless you and maybe 30 days worth of medicines. We had no community-based primary care clinics at that time. Federally qualified health centers were really at their infancy. And so what it meant prior to the expansion of Medicaid, literally as recently as 2013, is that if you were poor and you had a chronic condition and you lived in Cook County, what you were relegated to was visiting any one of the emergency rooms around the county, waiting for 6 to 10 hours to be seen for your chronic condition, being discharged perhaps with medicines or perhaps with just a prescription and no ability to get those medications. With the expansion of Medicaid and the development of our Medicaid managed care plan, what does that look like today? Well, if you came in today to one of our franchises, you would first be assessed for your eligibility for Medicaid. If you qualified for Medicaid, you'd get a card. And what that card would give you is access not just to Cook County Health and Hospital System services, but rather to a broad network. So our network consists of all of the federally qualified health centers in the county. There are about 140 such primary care homes scattered across the 950 square miles of Cook County. There you'd be empaneled in a medical home. You'd be assigned to a provider, either an advanced practice nurse or a doctor, who'd be able to see you. And just like probably everybody in this room, in addition to the preventive care that Dr. Hasbrook talked about in vaccination, you would be treated like a human being and given 90 days worth of medication. And you wouldn't have to visit the emergency room any longer. Now, when we did that, and we, in the course of the rollout of county care, were able to reach out and get more than 125,000 adults enrolled in Medicaid, what we found was a gigantic untapped demand for services. Most of these people do have chronic conditions of one sort or another, and many of them had been waiting for years for certain kinds of elective procedures to get done, and we've been providing those services. So we think that the social contract, admitting that we are spending as a country 17 or 18% of the GDP, doesn't speak to how those dollars were distributed. In fact, poor people were getting very little of that 17 or 18%. And when they were getting it oftentimes too late, at the time that a very advanced condition or an emergent condition forced them to receive care. Prior to the expansion of Medicaid, those poor adults, the only solace that they had, in the words of George Bush, our 43rd president, was everyone had access to health care. Well, that access was operationalized by the EMTALA law of 1986, which said that if you were desperately sick and you went to an emergency room, you couldn't be turned away from care. I don't think that that's access to health care. And so what we have today is a medical home-based model, and we think that that's going to actually improve health across the region. The last points I want to make are related to the finances related to this, because they are part of the social contract for people who live in Cook County. Dr. Colleen and Dr. Amaritas talked about where our tax dollars go. But I'll tell you very quickly in a couple of facts what's happened in our health system. So if you look at our audited finances from 2013 and to 2014, what we saw during a very short period of time is we went from a health system that took care of primarily uninsured patients to where we are today, where 70% of the people that we take care of are in fact insured. What that meant was from 2013 to 2014, our uncompensated care, that's care we gave to people who couldn't pay for their care, who were not insured, went from $500 million a year down to $340 million a year. That was balanced by an increase in Medicaid revenue to our health system of about $220 million in FY 2014. What we've also seen is over the last 8 years, a reduction in Cook County taxpayer dollars coming to our health system from $480 million in 2009 to what we're projecting for FY16 of $124 million. So a reduction in local taxpayer support augmented by an increase in federal tax dollars flowing in the form of expansion of Medicaid. So we think that those things are a good. I agree with Dr. Lumpkin and Dr. Hasbrook that the social determinants of health are critically important. And I'm going to end my comment with just one observation about that we're trying to wrestle with today. We do intake on all of these individuals when they come into our Medicaid health plan. We do what's called a health risk assessment. You ask about past medical problems and current living situations and so on. And when we do that, we've seen consistently 1 in 5 people coming into our health plan affirms that they're uncertain about where they will be living in the next 4 weeks. It's a screening question that we do to get a sense of housing stability. And so if we've got a person assigned to a medical home where they can get a vaccine, get preventive care, get their medications, but there's a 1 in 5 chance that they're going to be on the street in the next month, as Dr. Hasbrook pointed out, access to care isn't going to cut it. And the disorder that comes with being homeless is going to compound any problems that they have, adherence to any kind of healthy behaviors that they might have. It'll take a back seat. So I agree completely that this idea of wrestling with all those elements of the social contract, including education, housing, behavioral health services, and access to care are critically important. So I look forward to engaging in the conversation about that.
Thank you. How do you think the roles are evolving from different players who participate in the social contract? And do you think it's something that the average person thinks about or has expectations of?
Well, I'll give you 2 examples of that, and I think that they're increasingly complex. I think, in particular, Dr. Lumpkin alluded to this in his opening remarks. So one of the challenges that we've got, I think about a lot, my wife is a nurse. She's done a lot of work in public school nursing and the importance of community-based health and where there are opportunities to improve health for children in the schools. I think a lot of times school systems, particularly public school systems, often feel like responsibilities keep getting layered on top of them, that in addition to teaching, they're supposed to also be the place where kids get their meals, and maybe they're watched after hours while they're waiting for parents to come home for work. And one of the challenges that educators have is, where does their role end? Health systems have the exact same problem. We've got people who come to us and we think we're good at delivering health care, but as we've just been talking about, if we've also got problems with low education, limited English proficiency that get in the way of a group being healthy, we try to think about, well, should we start giving classes? Or is it our responsibility to start raising the education level? So I think this blurring of responsibilities of what the healthcare system is supposed to do, what the education system is supposed to do, what other social agencies like housing are supposed to do, becomes an increasingly complex one. I think that there are opportunities for this. One of the other initiatives that came out of the Affordable Care Act, as an example, is the Centers for Medicare and Medicaid Innovation. And one of the things that agency is doing is giving out so-called SIM grants. These are state innovation model grants, where they're saying, look, why don't you take some of these Medicaid dollars, and instead of them being tied to provision of services to individuals who come to healthcare outlets, start thinking about how you could use those dollars to improve health status in a different way. And states that are receiving those so-called SIM grants, one of the ways that they're thinking about it is to say, well, maybe the health systems ought to start partnering with local housing agencies, and maybe we can find transitional housing for people who we identify in care who don't have a place to stay, and will presumably lower the costs associated both with housing and with health care, because we've done studies even out of our own health system showing that if you can get a person into stable housing, a homeless person, then you can reduce the healthcare utilization that you'd otherwise see, the cycling either to emergency rooms or, increasingly as we see it, cycling to emergency rooms or the jail as a place for a homeless person or a person with behavioral health problems to go.
Anyone else want to jump in, or?
Well, let me say that by and large, I think part of the challenge of the social contract is that most individuals don't really think about health, and certainly don't think about governmental health or public health most of their days. You walk down the street, you go into a restaurant, Maybe you see a sign on the door that says the restaurant has been inspected, but other than that, you don't think about the whole chain of protection that's gone into the fact that when you walk out of that restaurant, go home and go to bed, you don't get sick.
Yep.
That really is the challenge. And we've done opinion polls and we've looked at it. The public has a high value for public health interventions. But when you tell them that the public health agencies have had dramatic reductions, they're just surprised. And many times they're alarmed. And it's not until points when all of a sudden we worry about things like Ebola,
Right.
or the H1N1, where suddenly the public health looks at them. And it's like that old movie, Home Alone 2, and there was this great scene where they were passing the baggage down the end of it and say, give this to Kevin. And when it got to the end of the line, Kevin wasn't there. Well, that's public health. That's governmental public health. People expect Kevin to be there. And the shocking reality is that Kevin isn't there. So that social contract, that the ability of the government to protect in many ways has been hampered without there really being a full understanding of individuals about that.
And I would just add, when we talk about social contract, I think we need to think in our minds social equity, social justice, and in terms of health, social determinants. We really need to focus upstream. So if you look at maybe many years ago where, in particular, poor folks had a lot of cavities and their teeth were falling out, that was causing a lot of medical cost, missed days of school, abscesses and infections, poor self-esteem, bullying, and all the things that come down the line. And then someone said, well, why don't we put some fluoride in the water way upstream to prevent these cavities from happening? And so now we don't have to deal with the sequelae and the outcomes of what happens at the end of the day. So really, public health or social contracts need to look at the social determinants. What's the underbelly of the problem versus what's the quick fix at the end of the day? Be it give them a doctor or give them a medical home, et cetera. Important, but not the most important when you're talking about things that are upstream leading to the problems.
One of the white papers talked about balancing individual rights and collective needs, and that made me think about Ebola, vaccinations. How do you see that balance in your work, and is it swaying too far in one direction?
I would offer the term connectedness, and I think that folks have to try to wrap their brains around the fact that we all are connected. So when you look at something like Ebola, if there's one infected person in a community, everyone's at some risk. And so sometimes we're very, I think, individual or egocentric. We're thinking that if I have access, if I have money, if I get the best care, I'll be okay. I can cocoon myself. But we're in a society where that's not possible. And even if you could cocoon yourself from the infection, you can't cocoon yourself from the medical cost that's being bared by folks who don't have access, which is driving up the cost of care. So I think if folks start understanding that there's a connectedness to vaccines, the connectedness to community response, the public health response, then I think that kind of takes one step forward in terms of helping folks to understand that you do have to balance, the collective good with individual behaviors, because we're all at some risk.
Yeah, I take that even a little bit further, because I think the vaccine one is an important question that's going to continue to play out. And I think, for example, in Cook County last fall, we saw an outbreak of measles in the northwest part of Cook County that was handled well, unfortunately, and fortunately, very small amount of morbidity associated with it. But let's talk about something much more common, influenza. All right, so every year, somewhere between 10 and 40,000 Americans die of influenza each year. I think last year in the United States, we had a couple of deaths related to Ebola. Ebola is not preventable by a vaccine. And while influenza is not completely preventable with the vaccines, they're not 100% effective, there's very good data that they reduce the risk of deaths related to influenza. In Illinois, we don't have any law about healthcare workers and influenza vaccination. When I became CEO of the health system, we had a pretty desultory performance about our own staff taking the vaccine. And I have serious problems with that, because I think when we've got franchises that are there literally to take care of individuals who are coming for care, many of whom are sick. They've got weakened immune systems, either by their intrinsic condition or by medications that they might take. I think that they've got an expectation when they come for care that they're going to be encountering a safe place. One way that we can take a step forward and be a safe place is for our staff to be vaccinated. I'm very happy that when we engaged in this conversation with our colleagues at the institution, particularly our labor unions, the overwhelming majority of them agreed to that, and we saw much higher rates of vaccination of our own staff last year. And I think because of that, we made it a safer place. I mean, I can tell you, I'm a critical care physician. I had the experience a couple of years ago of taking care of a pregnant woman who contracted influenza at the hospital that I was practicing in. This was not in Chicago. But she contracted respiratory failure while in the hospital for monitoring of her pregnancy, and she ended up under my care in the intensive care unit on a ventilator because somewhere in her hospital stay she was exposed to somebody who had the flu. That could have been prevented by vaccination. So I think when we think about those things and we think about the challenges in either schools or in private practitioners' offices and the position that they take about should people be vaccinated, we have to try and decide as a society, again, do we have an expectation that I may have a right not to take a vaccine, but I don't have a right, if I get sick because I didn't take that vaccine, to infect 10 people around me, whether that's at my workplace or at school, at a doctor's office or a hospital that I go to.
You know, a big part of this whole concept, and it's one that we think is essential to building a culture of health, is the concept that we're all in it together.
Right.
And we know as a nation we pull together. You know, those of us remember what happened after 9/11, and we as a nation pulled together. The problem is that many of these discussions happen on the national level, where in many ways reality sort of loses hold. We can remember the times in 2009 when the signs were being held at rallies, "Get the government out of my Medicare." We asked the public about issues related to vaccines, and they again bring up the whole issue about linkages to autism, when the original paper that was written on that was retracted because of errors in the scientific method. There is no data to link that. But again, we try to bring these conversations. We believe that if we are going to make progress, we really have to bring the conversations down to a community where people really identify with their neighbors. Vaccines are not 100% effective. That means that any child who gets a vaccine, 1 out of 100, 2 out of 100 will not be protected even though they got the vaccine. But they're protected because other children got the vaccine. So why should an individual parent be allowed to put other children at risk? That really, I think, is the social contract that we have. That is the responsibility of government and at the local level to make sure that everyone is protected, and that means all of us have our children vaccinated. And that really, I think, is the challenge to get that message across, but it has to be done in communities because people relate to their communities in ways that are different than politics at the national level.
So there was big news last week, the announcement of a new trauma center that will be built at Holy Cross Hospital in partnership with the University of Chicago. Lamar, I know that when you were at the state, you wrote a paper about the need for trauma centers. Can you weigh in on that development as it relates to social contracts and what we're seeing in our own local system?
Sure. So I was very happy to lead that effort in looking at a feasibility study to ask the question, should we address these trauma deserts, trauma center deserts, or places that don't have a trauma center to treat folks where there's very high incidence of violence. So I think that really deals with the access issue, and again, access is important, but it's not the whole picture. So when we're looking at deficits and gaps in terms of the access to, in this case, trauma surgeons and trauma services for penetrating injuries, gunshot wounds, and the like, we have to ask the question vis-a-vis the social contract: why is there a gap here, and what can we do to patch this gap and make sure that there's access to services when needed? That's important, and I think that it does a lot to bolster the community and the message that we do care about you as a community. We are related. Our humanness is related. We do care about what happens. But more important than that is really the upstream analysis of why is so much violence happening, and the understanding that it's not happening in a vacuum. And so that's why social contract gets us back to social determinants. And there's a reason why violence is happening in certain communities. There's a reason, that has to do with hope, that has to do with jobs, that has to do with destabilized communities, that has to do with housing and education, and self-worth and self-esteem. So that's where the social contract, in my mind, should really focus on. What are the determinants? What are the upstream things? As I argued in many of the commissions to discuss this issue, I said the answer is not to build more trauma centers or to have, an ER on every corner so in case someone gets shot, they can get care right away. The answer is to look at what's causing the upstream issues that's resulting in this interpersonal play, and this deadly play and this violence in these communities. So I think the social contract extends the continuum to having the access there, but more importantly, looking at the upstream things and addressing, if it's community development or if it's jobs or if it's hope or if it's education, those things that really can basically bend the arc of the problem to begin with.
John, you mentioned about choice, which can be elusive depending on where you live, for healthy foods. And I'm thinking about food deserts and food access. So when you see areas like that with the big gap, whether it's O'Hare or it's Roseland, whose responsibility is it to make sure that there are better options there, that there are better choices?
So I think frequently in our country where we come to a point of policy and we look for an either-or solution. Is it government? Is it individuals? Is it business? And I think that we can make a lot more progress if we take a yes-and approach. So we look at a community like Lawndale or Roseland, and we look at the food desert. First of all, there are myths. Is it economically not viable for there to be a major chain grocery store there? The answer is that's not true. What we've seen with the Food Trust in Philadelphia, they've made significant progress in helping bring major food chain stores into food deserts in inner cities. And those stores, by and large, over 90% of them, have been successful, financially successful. So it's responsibility there. But then there's another component, which is that government can play a role. There are major government programs, the SNAP program, the Supplemental Nutritional Assistance Program.
Food stamps.
Food stamps, as it used to be called. In some cities across the country, for people who are on food stamps, they will get $2 worth of food if they use it at a farmer's market, for $1 of food stamps. So ways that you can redesign the current governmental programs to encourage people to buy fruits and vegetables. By and large, people who, and this is really the conundrum, the obesity epidemic in this country, we find that people who are food insecure, in other words, they may not know where they're going to eat tomorrow, have a much higher risk of being obese. It doesn't seem to be, conventional wisdom. The data is very clear on that. But when you think about that, when you've got $1 in your pocket and you walk into a McDonald's or any other fast food restaurant and you look at the calorie count and you say, I got $1, I want to make this go as far as I can, you're going to be buying calories that unfortunately are not the best for you. Why can't we change these programs so people can actually afford the food that would be healthy for them, that they can cook in their homes, that enable their children to enter school at a healthy weight and graduate from school at a healthy weight.
Jay, can you talk some more about the Affordable Care Act and what kind of impact that's had on the Cook County system?
Yeah, I mean, I think, I've talked a little bit about the access part. I think that the other observation that I would make is that in this very short period of time where we've gone from being kind of the last refuge of those with no place to go to being a majority insured population that we serve, one of the other cultural transformations that we are facing as an organization is getting our own staff to understand that having insurance means having choice. And so we're finding that we need to do a far better job than we've done historically with the experience that the patients get when they come to our system for care. We have to be much more flexible to be there when they need us and how they need us. Our partners that are in community-based clinics learned this a long time ago, that when you're working with working poor populations, if you're not open in the evening or on Saturdays, you're not taking care of the patients that you serve. We've traditionally run our system as kind of, aside from the hospital services and the ER services, our clinic services have been run kind of during bank hours, and that just doesn't cut it. So that's a big transformation for us as well. I think one of the other challenges is we're still left with the fact that, particularly for adults, because in Illinois, virtually all children are covered and have access to care under the expansion of Medicaid and CHIP that happened back in the mid-aughts. But for adults, we still have 35 to 40% of the people that we care for who do not have access to care. They don't have access to insurance. And it's a very significant number. These are the people who are either because of their citizenship status or because of behavioral health problems or turmoil and chaos in their own lives. They can't get it together to get the paperwork done, which is pretty modest paperwork. Or alternatively, who perhaps make enough money that they could buy a product on the health insurance marketplace. They make too much for Medicaid. They should be going out to buy it on the marketplace, but they look at that marketplace plan that has a $5,000 annual deductible before the first dollar of care is covered, and they think that's not going to work for me. I'm going to take my chances, or I'll wait till I get a bill, and then I'll pay the penalty if I get a bill. And there are very significant numbers of those. So still today in the county of Cook, we've got an estimated 180 to 200,000 individuals who do not have insurance, and increasingly we see them at our place. So I think one of the challenges that we face is trying to figure out how do we get services to those individuals? How do we continue our historic mission of taking care of everyone the same way? Now, the reality is it's very hard to take care of everyone the same way. One example would be that a person who has a Medicaid card has access to transportation that would be covered by Medicaid. They've got access to behavioral health services. They've got access to substance abuse treatment in the community, and that's reimbursed and paid for under Medicaid, whereas uninsured folks don't have those same options. The last piece that I would say about that is that I think one of the wonderful kind of cultural transformations for us as an organization is recognizing that we can't do it all and that we have to partner. So I am as guilty of this as the last guy, that, practicing for as many years as I have as a physician at Cook County, if I couldn't get you the care, I would commiserate with you a little bit, and I'd say, I sure wish I could get you that care, but I can't. And that's where it would stop. And we're recognizing that, first of all, we don't have the expertise to provide the whole spectrum of care. Some of the skilled nursing and rehabilitative services, long-term care, never has been in our wheelhouse. We've historically, as an organization, been an acute care hospital as our main strength. And so by developing the network of providers in county care, which included those kinds of visiting nurse, home care services, durable medical equipment, we've realized, there are some things we shouldn't build. We should buy them, we should contract, and we should partner with them. We're also doing some things now around behavioral health where we're working with community-based behavioral health social service agencies. They know, as Dr. Lumpkin was pointing out, they know the community, they know the folks that they're taking care of, and they're probably better at it than it would be if it took us 3 or 4 or 5 years to build up that service. So one of the things that we're doing is we're learning to partner and go beyond our 4 walls, and I think that that's been both bracing and for some people threatening, but in many ways much more fulfilling for the organization. I think it's more reality-based, and I think we're going to continue to transform in that way.
Yesterday, the U.S. Census Bureau released numbers that said the number of Americans without health insurance dropped by 8.8 million to a total of 33 million. Lamar, you said that just because you have access doesn't mean that you're healthy. Can you talk a little bit about that?
Okay, so there's a couple of things. One is there has to be some education with the access. So I get a card, but now I need to know how to use it, when to use it, how to be supported in scheduling my first appointment, what it means to get their transportation, those types of things. So I can even just use the card that now I have. Somebody needs to tell me that I have access, what my card can and cannot do, and the importance of how to use it and how frequently to use it. So that's a whole another part that has to come other than just sweeping somebody in because they meet the economic criteria. That's one. The other thing is that we got to understand, let's just say the mom that has a kid that has asthma, and the kid is coming in 2, 3, 4 times when he has a life-threatening asthma attack. And so by having access to care, and they get it anyway through emergency care, very, very costly at the very, very terminal end of an extreme presentation of their asthma. So they have access to that, but then they go right back to the same home. And in that home is a leaky roof.
Right.
And there's mold in the walls. And there's insect pieces in the carpet and in the fabric and in the couch. So we're not dealing with the upstream pieces that's actually resulting in that kid coming into the hospital in a near-death situation 4 times a year. So what if we had a community health worker or visiting nurse that we then decided to fund who can actually go out to the house and address and remediate those problems that's actually causing the problem? So that's the difference between having the access to care when you need it, when you're sick, when you're about to die, and addressing those upstream social determinants of health. And so, that's where the social contract really has to focus again on those social determinants, those contextual issues.
But that said, I think we need to pause and note 8.8 million more people have health insurance. And the data is absolutely clear. There was a series of studies by the Institute of Medicine that people without health insurance live sicker and die younger than their peers. And those studies have been repeated and have consistently shown that. And in fact, when some of the Healthy Interview survey, most recently, the results came out about a month ago, there's a question that they ask on the survey: have you foregone health care because of cost in the last year? The number of people who responded yes to that question has gone down because of the Affordable Care Act. So the first step is to get people insurance. The next step is to put that insurance and that care and access within the context of the broader things that we need to do to actually have a healthy society.
It's the both and.
Mm-hmm. And I think I think it'd be incomplete if we didn't make a couple of observations about this. Again, it's not a problem of not having enough money in the system. The expenses, as Dr. Lumpkin has pointed out, the expenditures in this country on health care far outpace that of any of the other Western developed countries. But the distribution of those expenditures is incorrect. And I think, again, we all tend to think about the tax support, for instance, that comes into a health system like mine, and we're grateful that that exists. We need to recognize that other health systems are getting gigantic tax breaks in their land, in sales taxes that happen within their walls, in relief of taxes on the borrowing that they do. So people shouldn't be confused about the fact that only public health care systems with that in their name and with that in their mission are being supported by tax dollars. There's a gigantic amount of tax relief that go to the so-called not-for-profit health systems, that they're benefiting from that, and there's supposed to be a community benefit that goes along with that. They're supposed to demonstrate their community benefit and do a needs assessment and then talk about how they're doing that. I think that many systems do that fairly well. There are other systems that I think game the reporting and talk about how they meet their community benefit that is justifying the tax relief that they get. And I think that that's something that if we were able to uncover that a bit, we could get to the remainder of those people who are uninsured and get them the care that they need. I think it's just it's a national shame that we've got that proportion of people who still don't have that fundamental access. And the idea that they don't pay is nonsense. They pay with dignity, they pay with their self-respect, they pay with their time, and as Dr. Lumpkin pointed out, they pay with years of life lost. And, there have been studies that show that these folks are contributing to society. They're the people who are washing our windows, mowing our lawns, babysitting our kids, preparing our food. I don't think in 2015 that's something we should be looking at.
I'm going to turn it over to questions now. There's somebody walking around with a mic, so if you raise your hand.
Hi, Michelle Kelly, School of Public Health. Just thank you so much for your excellent analyses. I did want to add to the piece about the fact that we spend so much more on healthcare than our other countries that have national healthcare as a mandate, as a right. We also spend so much less on social infrastructure. I can't remember the article in Health Affairs.
Yeah.
Maybe you know what I'm talking about.
Yeah.
So that would really make a difference if we had that policy and fiscal realignment.
Oh, this is a good observation. So this is I think if this is the same thing that we're thinking about, when you look at those other OECD nations that spend, on average half what we do GDP-wise, they almost match us by taking that half that they didn't spend and investing in things like education, public health, safety, and so on. And so it turns out they're about the same, whereas we spend a lot on the healthcare part and less on the other.
And I think it's important to recognize the elephant in the room, too. When you do the same comparisons for those OECD nations, people in this country have fewer visits to the doctor and stay in the hospital for a shorter period of time. So it's not only where the priorities are for spending, but the fact is that the cost of care, I'm sorry, not the cost, the price of care in this country is significantly higher. So it's how much we spend on pharmaceuticals, devices, physician salaries, and other things, as well as the fact that we spend them on the wrong things.
I agree.
Hi, my name is Michael. I suppose this is a question mainly for Dr. Shannon, but maybe for the whole panel as well. Dr. Shannon, you mentioned, you alluded to the pent-up demand for care before and then after the Affordable Care Act went into effect. It seems to me before in Cook County there were people that were insured, there were people that were not insured, and now we have this third group, people newly insured, either through Medicaid or through the health insurance marketplace. Has it been your experience that pent-up demand, we saw a spike in usage of that third group, and now it's sort of leveled off as they've gotten used to the new system, fewer ER visits, more primary care physician visits?
Yeah, it's a good question. I get asked a lot, so now they've got insurance, no more ED, right? Not so much. I mean, I think Dr. Hasbrook alluded to this. The average person who's a new recipient of Medicaid is about 48 years old and has lived for 30 years plus without insurance, perhaps was raised by parents who were uninsured. And so the idea that person grew up with was, if I'm sick, I go to the ER. It's always there. Smart, capable people take care of me. I walk out of there at 24/7, 365, works pretty well. So turning that around, and as Dr. Hasbrook talked about, educating them about what does it mean to be able to have a medical home where you can go and have a relationship where you get assessed for a lot of your health behaviors, maybe get some health education, which you virtually never get in an emergency room visit, get an opportunity to get stabilization and addressing of health behaviors like physical activity, diet, smoking, things of that nature can't be underestimated. So it's going to take a while to bend that curve. I think the other observation that we've made, and we're hoping to do some more detailed analysis of this and publish it, is that when we looked at the first 10 months or so of the so-called Medicaid expansion adults, we found out that the commingling of their chronic illnesses with behavioral health is huge. To just give you a sense of that, about 10 cents out of every dollar, and this is not even including the drug costs, about 10 cents on every dollar that we're spending for those individuals are related to problems of behavioral health or substance use. And this is a gigantic driver, again, not only of costs, where we see people cycling in and out of the hospital or the emergency room, or again, the jail because of untreated mental health conditions, but also the morbidity that's associated, which is profound. And if you start to look at adults who've got chronic illnesses and behavioral health problems, they die tens of years earlier than they should. And so trying to get to that, and that's not even as easy an issue of getting them insurance coverage because there's a shortage of skilled providers out there. And so again, how we lift up the primary care community and start to incorporate and integrate the skills to be able to handle behavioral health. There are not enough psychiatrists in the world to take care of the folks who have got these problems, and we've got to find out how we get ahead of them. Last observation I'd make about that is one that Dr. Hasbrouck alluded to. Many of these problems were created at their birth because they were born of low birth weight, ended up in a neonatal intensive care unit as they're beginning to life, or they were born with alcohol and drugs in their system, or they were born with any of those things and then grew up in a home that might have lead paint, so their brain development was delayed. And these things compound themselves, and then they manifest as a undereducated adult with behavioral health problems, and it's just a disastrous cocktail, particularly if that individual ends up with a chronic illness. So that's a big problem.
And just one other point, and I think that there's been a tendency to link access to health insurance with increases in emergency department use, and that started out with some of the analysis that was done in Massachusetts, right, where they saw a spike. There was a study that was done that compared the increase in emergency department use in Massachusetts with neighboring states that hadn't undergone health reform. And in fact, the rate of increase was the same. So there's a general overall usage increase in emergency department use that's not directly tied in with access to health insurance.
Hello, my name is Sylvia Alston, and I am principal of Right to Win Communications. It's a marketing and PR firm focused on multicultural communications and healthcare communications. Dr. Hasbrouck alluded to some of the upstream impacts in terms of people, newly insured people, taking better care of themselves and responsibly accessing healthcare. And there was a point made around, educating those newly insured to what their card can and can't do and how to access the system, which those of us who are better situated economically kind of grow up learning how to do. To what degree is that communication, that education happening? Where is the opportunity for us in increasing that, their education? And on the flip side of that, is there anything being done in terms of communicating with the healthcare community, healthcare providers, in terms of communicating and working with and educating those patients who are brand new to the system?
Well, I'll speak again, I'm sorry, just from my own experience with our Medicaid plan. At the outset of things, we had to do grassroots. Dr. Lumpkin correctly said, you can talk about this stuff at a national level, but where things really happen is at the community level. So you'll recall, perhaps, if you live in this area, you never saw billboards or television ads or radio ads for county care in 2012 and 2013. That's because we were out at schools and churches and community organizations talking about it at the ground level. That turned out to be terribly effective. But just to give you an example of how that can slip, you know, you get a Medicaid card in Illinois, you lose it after a year unless you go through a process called redetermination, where you show you're still in the county or the state, you're still poor, and so on. We're going back to the community to do that kind of education, because otherwise we're finding out, and no surprise, the healthiest of the individuals are finding well, and these Medicaid adults don't have their benefits tied to SNAP benefits or housing benefits that otherwise might remind the mom or the dad who's been in traditional Medicaid, hey, it's time to fill out my paperwork again. So we're going back to the community. We think it's really at the community level and also at the provider level. So those offices that are providing care are also a good opportunity to remind people about those pieces.
I would add to that in the Get Covered Illinois campaign that really helped to educate the general lay public about these benefits. Again, going to the grassroots level and bringing some of these community leaders, educators, and other folks that have touch points with them to educate them as to what they have and how best to use it is very important as well. The in-person counselors that kind of walk you through your benefits and walk you through your eligibility, those things are very important. The use of social media, basically trying to change the cultural and some of the social norms of entitlement. I should be entitled to some level of health care. Where do I fall? What do I get? And then how do I use it? So it is very important to do it at that grassroots level.
We have time for one more question.
I'm Christy Kirsch. I'm a physician in rehabilitation medicine. I'm here at UIC in the Department of Disability, Human Development, and Medical Education, as well as at Schwab Rehabilitation Hospital, which is part of the Sinai Health System, one of our safety net providers. But I've spent a lot of my career also in some of the most privileged healthcare systems in Chicago. And I'm directing my question really to you, Dr. Shannon, but I'd welcome input from any of you. I think this issue of community benefit and not-for-profit is a very, very important one, and I'd be interested in some policy solutions that perhaps you have in mind for solving this. I think it's absolutely true that some of our wealthiest healthcare systems that are not-for-profit get to define what they consider community benefit. And is there some gaming? Yes, I think there is. And yet you look at our safety net systems that have antiquated hospitals and equipment and EMRs, and what's considered community benefit, and how do you get access to the capital to build a new building? We're building a lot of new hospitals in this city, but you can't say they're going in the neighborhoods that most need new hospitals. So I'm curious, what would you consider as a reasonable approach to trying to hold healthcare systems that are not-for-profit and have to declare community benefit to get their tax break? What would you consider some reasonable policy?
Well, I think you touched on it in your question, and that is, and this is not what a simple critical care doctor was raised to be an expert on, but I think you touched on it, and that is the definitions of what dollars get to be counted as going toward community health benefit. If I've got a tax protection of this much, if I can define what kinds of things I get to count against that thing, if the policy led to a tighter definition of those kinds of things, and there was a gap, and I had to use that gap to contribute to some kind of a fund that would then go to cover uninsured individuals, that may be a way to do it. I think that right now the reporting leaves enough wiggle room that people are able to get away with those kinds of things. I think that's where I'd start.
I would just add to that there are assets in every community, local health departments, for instance, that do every 2 or 3 years these community health needs assessment, looking at the community as the patient and not just the individual, which is often what health care delivery systems do, and prioritize what's ailing the community, what's making the community sick, and prioritizing those things. So one of the policies that I would suggest is that there's a mandatory working together and collaborating with your local health department that does this 24/7, 7 days a week.
So I have a much longer response, but I'm also looking at the clock, so all I'm going to do is say ditto and hand back to
Okay.
you.
We are going to end on time. Thanks so much to our panel for your wonderful insight. Thank you for your questions. And one housekeeping note, there's a